Good afternoon and Assalamu alaikum to everyone. I'm Najma, Dr. Najma, pediatric oncologist, moderator of this session. This is the last session of pediatric oncology, and today we have wonderful talk. Our first talk is on post-cancer treatment challenges in teenage and young adults. Uh, this is by Dr. Aziza Shah. She is well known to all of us. She is a graduate of Dow Medical College and has special interest in childhood lymphoma, leukemia, HIV-associated malignancies, late effects in the cancer survivors. And currently she is working as a director of the pediatric hematology oncology at the Georgetown University School of Medicine. Dr. Aziza. Hello?
Coming on board.
Yes, okay. Okay, you
All right,
can
let me just
you
share
can
my
share your
screen. Yes, let
screen.
me just share my screen. Here we go. All right, can you see it?
Yes, now I can.
All right, let me just make it complete. All right.
Yeah.
So I guess it's early morning for me and it's afternoon for you all. So good afternoon to everyone. And it's a real pleasure, Najma, to be invited to speak at the Shaukat Khanum Virtual Symposium today. It's really amazing what COVID has done. And in spite of that, we continue our educational and other activities related to our profession. So I was asked to speak today about post-treatment challenges in adolescents and the teenage population. The population that I thought I would just refer to very briefly is also the young adults, because as you know, we have a whole discipline now, the AYA discipline, which is adolescents and young adults, and most of them with pediatric tumors tend to have a better prognosis today because of the way we have modified their treatment and we pay more attention to them. So moving right along, the incidence and the significance of cancer in children and adolescents, approximately 15,000 new cases of cancer are diagnosed per year in the United States between the ages of 1 and 20, which means that 1 out of every 285 children will be diagnosed before the age of 20. The leading cause of non-accidental death, ages 1 to 20, is cancer in the United States, and approximately 1,960 estimated deaths happened in 2014, and the numbers remain a little higher than that, but I don't have the most recent figures. This is the latest that I could find. But the important significance of cancer in children and adolescents is that with a median age of 10 at diagnosis, the life years lost are 65 years per case, which means 710,000 life years are at risk every year, secondary to pediatric and adolescent cancers. So some key statistics for cancer in adolescents. About 5,000 to 6,000 adolescents between the ages of 15 and 19 are diagnosed with cancer every year in the United States, and 1/10 of them die of their cancer, 500 to 600 adolescents. Cancer is the fourth leading cause of death in this age group, only behind accidents, suicide, and homicide. It occurs equally in teenage boys and girls, but survival rates are higher in girls than in boys. If you look at this diagram, it actually shows you it's split into children between the ages of 0 to 14 and adolescents between the ages of 15 to 19. If you look right at the bottom, the total number of children is roughly about 10,450, and the number of adolescents between 15 and 19 is 5,330, which is how we get those numbers of 15,000 total below the age of 20. But more interesting is the kind of cancer that we see in children. So the top 3 malignancies of childhood are acute leukemias, acute lymphoblastic leukemias, brain and CNS tumors, and then the lymphomas, non-Hodgkin's and Hodgkin's, followed by all the solid tumors, etc. But in the adolescents, it's different. It's lymphomas first, particularly Hodgkin's lymphomas, number 1. Then there's thyroid cancer, brain and CNS, testicular germ cell tumors, as well as ovarian tumors are seen in this population. And then you have the lymphomas and leukemias and melanoma as well. So it just goes to show that if you split the population up between children and adolescents, the kind of malignancies that you are going to see in the adolescents and the frequency of those malignancies is going to be different than that what you see in children. All right, and this shows you the 5-year observed survival rates for 2 time periods, again split between 1975 and 1979, that means the late 70s, and then more recently between 2003 and 2009. And if you go down the list, leukemias to lymphomas to rhabdomyosarcomas, testicular and ovarian tumors, and melanoma, you can see that there's been a significant improvement in the survival rates. And most numbers today lie somewhere between 70 to 95%, depending on the kind of tumor we are talking about. So there's been significant survival in all these patients, irrespective of whether they are children or they're adolescents. So adolescents and young adults are actually a different group that has to be looked at very carefully, because they get cancer at a time when their bodies are undergoing physical changes and growth. The adolescents may just be reaching developmental milestones, like, for example, graduating from school, in some cases from college. The young adults may be starting a career. They may be thinking of getting married and having children. And when that diagnosis of cancer comes, it throws everything into disarray and puts them at very high risk for developing not just medical problems, but also psychosocial sequelae. And the challenges that are unique to adolescence, which then can be mirrored later when you follow them through survivorship, are social and emotional issues, dealing with the physical changes that cancer or the treatment of cancer brings upon them. For example, weight gain, scars from surgery, things that may never go away, sometimes permanent hair loss. They worry that the cancer may return or develop new healthcare problems. There's resentment in that population at the treatment that they had to go through while others did not, and also the loss of their independence. They are secretive and they do not want to tell people about their cancer for fear of being treated differently. And unfortunately, all these emotional issues, unless taken care of during active treatment, last well beyond their treatment and therefore through their survivorship period as well. So as a result of all these issues that we see in adolescents in particular, there is non-compliance during treatment. They don't communicate very well with their oncologist or their oncology teams. Invariably, a large percentage get lost to follow-up and are at risk for developing serious late effects, end up receiving inadequate to no survivorship care. So that is one of the big problems and the challenges in treating this population of patients. So let's talk about survivorship now. We know that almost 85% of all children and adolescents diagnosed with cancer survive more than 5 years, and the majority of them are cured. Currently, there are more than 500,000 childhood cancer survivors in the United States, and they say that 1 out of every 530 adults between the ages of 20 and 39 today is a cancer survivor. With more than 100,000 cancer survivors in college, the numbers continue to grow. But treatment is not without cost, because even though we know that almost 85% of all children and adolescents with cancer become long-term survivors, many manifest an accumulating burden of physical and psychosocial late effects of cancer treatment in the years after therapy is done. So what are the late effects of treatment in this particular population that we're talking about? So, and the AYA population, as we call it, these cancer survivors are vulnerable to the complications related to the cancer or treatment, just like childhood cancer survivors. Their risk of developing long-term side effects depends again on 3 things: the type of cancer they've had, the treatment and doses used, whether it was chemotherapy, radiation, surgery, bone marrow transplant, and what doses were used for them, and more importantly, the age at treatment. The majority of late effects of treatment we're all aware of become apparent 15 to 30 years after treatment is finished. And having run the cancer survivorship program, first at Georgetown and now at Sinai Children's Hospital, for the last 25 years. It is amazing what I have seen in the last 2 years. Patients that I had treated when they were 3 or 4 or 5, young males and females that I had treated when they were between the ages of 15 and 19 are now showing up with cardiotoxicity. This year alone, I have diagnosed 4 second malignancies. Okay, so let's talk about the adolescent population and survivorship. Many of them are still pubertal or just post-pubertal at the time of diagnosis of cancer. This makes them so much more susceptible and sensitive to treatment with chemotherapy, radiation, mutilating surgery, and you can take it further to bone marrow transplant. We're not quite sure what the long-term side effects of the new targeted therapies will be. So these young adults and adolescents are at high risk, we said, for medical and psychosocial sequelae from cancer and its treatment. It is well known that these AYAs who survive cancer for more than 5 years have a higher relative risk of developing a secondary malignancy compared to children, as well as to older cancer survivors. So this is probably the most vulnerable population for second malignancies. They have concerns about fertility and whether they will be able to have children. They are more dependent on their parents compared to their peers. They have difficulties in intimate relationships and employment. And younger adolescents have lower levels of well-being. They experience significant anxiety, transitioning from active treatment to the survivorship phase. So these are some unique survivorship issues that we see in this population of patients. Let's give you some examples of late effects in these cancer survivors. Heart disease after treatment with anthracycline chemotherapy or chest radiation. Learning disabilities, and you may say that learning disabilities in leukemia and brain tumor survivors generally occur in younger children, but they do occur in this population too, as I'll mention further, treated with radiation or chemotherapy to the brain. Breast cancer at an early age in female survivors of Hodgkin's lymphoma who received radiation to the chest in their teens. Post-traumatic stress syndrome, anxiety and depression. Infertility and premature menopause from radiation to the abdomen and pelvis for sarcomas, and chronic pain and fatigue. These are characteristically seen in the adolescent, teenage, as well as the young adult population. So let's go through the late effects, talking about them one by one. The effect on growth and development can occur in linear growth, for example, right at the pubertal stage when they're about to gain height if they need to get radiation. It affects their intellectual function and sexual development. Vital organ functions, there is no organ that is immune to the effects of the treatment for cancer, whether it's the heart, lungs, thyroid, kidney, liver, or the immune system. Late effects are seen in this population on fertility and reproduction, particularly second malignancies and psychosocial issues, as I mentioned earlier, as a result of which this population is also at risk for early mortality. Neurocognitive issues, once again, you can say the developing brain is usually before the age of 5. However, if adolescents get radiation, they can also get mild cognitive deficits to major learning disabilities, and most of them are centered around impairment of attention and memory and processing speed. So what tumors can you think of in adolescence that could cause this? Of course, brain tumors and ALL patients are most susceptible, but stem cell transplant or radiation for tumors of the head and neck is also another population which can result in getting neurocognitive issues. What about the radiation effect on growth? Early or delayed onset of puberty, generally in this case, it's delayed onset of puberty, and direct inhibition of vertebral growth following spinal radiation more than 35 grays, which can also result in deformities of the spine. What about the heart? The cardiovascular system, we know, is extremely vulnerable to cancer therapy. So this population of patients, that is the adolescents, young adults, when exposed to anthracycline can present either with asymptomatic cardiotoxicity or cardiomyopathies, left ventricular dysfunction, even heart failure. Patients who with Hodgkin's disease who get mantle radiation are also at risk for coronary and carotid artery disease. Other risk factors for cardiotoxicity: females, the younger the adolescent, high cumulative doses of anthracyclines, and radiation involving the region of the heart are all reasons why somebody could have problems with cardiotoxicity 15 or 20 years after completion of treatment. Fertility, very, very big effect in adolescents and young adults. Males, sterility can occur following a dose of 10 grams of cyclophosphamide or low doses of radiation. In females, interestingly, the ovaries are relatively resistant to chemotherapy-induced damage. Very sensitive to radiation though, and therefore the side effects that we see in women are pubertal delay and premature ovarian failure, osteoporosis, and early coronary artery disease. And once again, age at treatment is significant. So this is one thing that as pediatric oncologists and as those who take care of adolescents tend to forget to talk to them about, which is premature ovarian failure. The risk factors for premature ovarian failure in females is age between 13 and 19 at the time of treatment, those who have received high-dose chemotherapy, including alkylating agents, or whole abdominal radiation for Hodgkin's disease or Wilms or other solid tumors, and those who may have received cranial irradiation. But the highest risk factor is TBI in the preparation for bone marrow transplants, where almost 100% of patients over 10 years of age and 50% of the patients under the age of 10 will develop premature ovarian failure. So counseling of this population of patients, talking to them about it, and also reminding women, unless they've really had TBI, that they need to have their children early, because premature menopause in this population can occur as early as 35 years of age, usually occurs in the early 40s. Okay, other late effects: thyroid cancers seen in this population more than you see them in children. So hyper and hypothyroidism and thyroid cancer as a result of radiation that you may have given them as well. Metabolic problems such as osteoporosis and osteopenia and metabolic syndromes. But this is an important piece. Second malignancies, the rate of second malignancies in this population when treated for cancer is high, and they can present as either AML or other leukemias. Skin cancers, basal and squamous cell, quite commonly seen now in patients who've had cranial irradiation. Brain tumors, malignant and benign. Just this year, we diagnosed 3 meningiomas. Cancers in the field of radiation, soft tissue sarcoma, squamous cell carcinoma, and osteosarcoma. I've had 2 squamous cell carcinomas of the tongue in patients who were 14 and 17 years of age when they were diagnosed and got radiation as well as high-dose chemotherapy and a bone marrow transplant. Okay. Psychosocial issues, once again, more unique in this population than you see in childhood cancer survivors. They are more likely to present with mental health disorders, chronic pain, fatigue, sleep disorders, and a significant number of them suffer from post-traumatic stress, which can occur months to years after treatment, may be associated with anxiety and other psychological stress. So keeping all this in mind, we can understand the importance of following this patient population through the survivorship programs. In 2005, the Institute of Medicine came out with a report which was labeled From Cancer Patient to Cancer Survivor, Lost in Transition. It highlighted the need to recognize survivorship as a distinct phase in cancer care to address the needs of all survivors. The recommendations were that all patients must receive a customized end of treatment summary at the completion of therapy. All patients, particularly this population, should receive a survivorship care plan that details a plan of ongoing care, follow-up schedules for visits and treatment and testing, recommendations for early detection, and management of treatment-related effects. The National Academy of Medicine around the same time came out with their recommendation that promoted lifelong risk-based survivorship care for the growing population of adult survivors of childhood and adolescent cancers as well. And as a result of both these directives, survivorship programs now exist at almost all institutions that belong to the Children's Oncology Group in the United States. The goal of these programs is to follow survivors carefully for anticipated late effects using the Children's Oncology Group survivorship guidelines, to educate the survivors about their cancer and the treatment, to provide education on risk-taking behaviors, healthy lifestyles, fertility, employment, and health insurance issues, and finally, to share their care with their primary practitioners or their pediatricians, or in this case, in the adolescent and adult population, it could be a family practitioner as well. The model that is used, multiple models are used for survivorship clinics. Some survivorship clinics exist in adult oncology programs, others exist in pediatric oncology programs, some exist in the community. This is the model that I choose to follow in my survivorship program. It's called the shared care model, where multidisciplinary teams provide lifelong follow-up at pediatric oncology treatment centers. So the oldest patient that I see in my clinic, interestingly, is now 50 years of age. Relationships are established with the primary healthcare provider in the community. My patients come to me for an annual comprehensive follow-up at my pediatric facility. Routine healthcare needs are met by the primary healthcare provider, but a complete treatment summary is provided to the primary MD and close communication is maintained between the two services. This is the brochure of my survivorship program. This young lady was diagnosed at the age of 13 with acute lymphoblastic leukemia. She received cranial radiation. She has had some stunting of height, if I could call it that. Secondary to the radiation, she's already had about 4 basal cell carcinomas, but then she is now 35 years old. And due to the education that she received through the survivorship program, which made her realize that she was at risk for premature menopause, she had a baby 2 years ago, and she's pregnant now with her second child. She gets high-risk care through a cardiology program when she is pregnant, and she's followed by a high-risk OB as well. So it just goes to show that adolescents and young adults are a population of patients who are at high risk for falling out of treatment or never coming back for follow-up. Their medical problems are unique and their psychosocial problems are unique. They're at high risk for infertility, psychosocial disorders, and many of the other things that I already mentioned to you, which is why their follow-up is extremely important and can be done through a structured cancer survivorship program. So in conclusion, adolescent and young adult cancer survivors can have long-lasting physical and psychosocial issues well beyond the immediate post-therapy phase. Addressing these issues through a survivorship program is essential. Education and communication with their healthcare providers is key to prevent them from being lost to follow. Thank you very much.
Thank you, Dr. Aziza, for such a wonderful talk and addressing the challenges of the teenagers after treatment. Our next speaker is Dr. Asim Bilkrami. He is acting professor of pediatric hematology oncology at AKU University, and he is also president of the PSPO and POIM and a member of the scientific committee of the PSYOP. His topic today is overview of infantile leukemia. Dr. Asim, please unmute your mic and share your screen.
So Najma, I'm having a little bit of a problem with my laptop, so you'll have to display my slides from there. So I'm going to start by thanking you all for inviting me to the 19th Shaukat Khanum Cancer Symposium. I think I've attended almost, 18 of them, so which is fantastic. So I've been asked to talk about infant leukemia, and I have no conflicts of interest, financial or otherwise, to disclose. So we're just going to talk a little bit about the epidemiology and background. Now, the first thing, of course, is that the definition of infancy. So infant leukemia is a leukemia that occurs in children who are less than 1 year or less than 365 days of age. And sometimes it's become a little better now, but several years ago, there was a lot of controversy in this, and people were very lax about what they called infancy and what they did not. So in the USA, the rates for infant leukemia is 40 babies per 1 million babies suffer from infantile leukemia. And this is really the same frequency that one sees with brain tumors or with neuroblastoma of infancy. So it's a rare disorder, but it's something that is going to be seen by pediatric oncologists, particularly pediatric oncologists in relatively busy services. So among infant leukemia, ALL and AML occur in almost equal proportion. This is, of course, as you all well know, very different from what happens in post-infancy, where ALL is about 4 times as common as AML is. For ALL, there is significantly more B-cell ALL than T-cell ALL. And T-cell ALL accounts for less than 5% of all ALL that is seen. In older children, as you all know, it can range anywhere from between 10 to 20% of all ALL that is seen. And for AML, there's significantly more monocytic or myelomonocytic leukemia as compared to the other subtypes of leukemia. ALL is less common than in younger children, while AML is more common. And this obviously goes along with the figures that I've given up ahead above, where I'm saying that AML and ALL is about equal. So if they are equal, then that's less ALL and more AML. All right. So there's certain characteristics, clinical characteristics, which impact the prognosis of these patients. Firstly, infants present with more high-risk features in general. Now here I'm talking not specifically about ALL or AML, but leukemias in general. So these patients present with much higher white cell counts. They have more CNS disease. They have more hepatosplenomegaly, and really leukemia cutis, which is really rare in the post-infancy, is really seen not infrequently in infants. ALL infants has a far worse outcome than older children. AML in infants has an outcome that is similar to older children with the same AML subtypes. And we'll talk a little bit more about all of these things as we move forward. All right. So we can't talk about infant leukemia without talking about genetics. And of course, the most important genetic lesion that we all know about with infant leukemia is the MLL gene rearrangement. Now, of course, the name for MLL has changed. It's now called KMT2A. You know, I think they keep doing this to keep us on top of things, to ensure that we don't forget. So now it's no longer MLL gene rearrangement, it's actually a KMT2A balanced translocation. What is important about this is that this is what's called a promiscuous gene, and really there are 94 different partner genes that have been identified as translocation partners for the KMT2A. And what happens is there's a fusion of the N terminus of the KMT2A with the C terminus of a partner gene. In infant ALL, 4 partner genes account for over 90% of the cases. The most common is what's now called AFF1, used to be called AF4, and this is the gene that the translocation that results in the translocation 411. The next one is the MLLT1, formerly known as ENL, about 20% of cases, and this is the 1119 translocation. The next one is MLLT3, formerly it was AF9, 17% of translocations, and this is associated with the 911 translocation. And finally, the MLLT10, formerly the AF10, about 5%, which results in the 1011 translocation. In infant AML, three partner genes account for about 2/3 of the cases. MLLT3, as above in ALL, which causes 9/11 translocation, MLLT10, which is results in the 10/11 translocation, and ELL, which is a different gene on chromosome 19, but results also in an 11/19 translocation. So why is this so important? Why is it that there's so much KMT2A translocations or rearrangements that we see in infancy? Well, firstly, these rearrangements are acquired in utero. However, they have a really short latency as compared to other prenatal translocations. The most important prenatal translocation is the E2X, the 21 translocation, the ETV6. Why am I forgetting this? Translocation, which is seen in ALL, which also has a in utero origin. However, its presentation as leukemia occurs at a median of 3 years of age. So a much longer latency period. The only other situation where KMT2A rearrangements are seen is following topo2 isomerase inhibitors. So following sort of etoposide use. There's been an association that's been documented with increased KMT2A rearranged leukemias in children where the mothers were exposed to dietary flavonoids. And I've got the references at the bottom of this, reference at the bottom of this slide here. The second is that there is a germline genetic susceptibility that may also play a role, as they've shown, as the number of SNPs or single nucleotide polymorphisms have been shown to correlate with the risk of infant leukemia. So these may actually be working together where you've got the genetic susceptibility that may interact with dietary flavonoids, and that results in the KMT2A rearrangements. So how does KMT2A rearrangement impact on the prognosis? So the prognosis is different in ALL than in AML. So the KMT2A rearrangement is independently related to a negative prognosis in infantile ALL. It's also associated with other poor risk markers, CD10 negativity, aberrant expression of myeloid markers, and all of this suggests that the leukemias that arise following KMT2A rearrangement are very immature and arise from immature lymphoid progenitors, or from not just lymphoid progenitors, but from pluripotent stem cell progenitors. Infant leukemia cases can be of ambiguous lineage, either mixed phenotype acute leukemias, or without any differentiated markers, which is going to be your acute undifferentiated leukemias. All of this points towards very early, ontogenically very early effect of the leukemia, of the stem cell that is being affected in here. In infant AML, the KMT2A rearrangement has less impact. 11/19 translocation may be a better prognosis. 10/11 translocation may be a poorer prognosis. However, overall, it doesn't have that same effect on the prognosis as it does in ALL. So I'm going to start off by talking about AML, and that's going to be fairly brief. And then we'll move on to ALL, which is a much more involved issue here. So in AML that occurs in infants, the treatment response is similar to that in older children. So therefore, we do a similar risk stratification, just like you would do in older children AML, where you classify them into low risk, medium risk, or high risk based on their genetics, and their response to treatment, you would do exactly the same thing in infant AML. Of course, the good risk translocations, the inversion 16 and the 821 translocation, for example, are less often seen in infant AML. And so many more of the infant AMLs end up being medium risk or high risk. However, their response is identical to that you would see in medium risk and high risk AML for older children as well. And that KMT2A rearrangement in the risk stratification schema varies. Some institutions are using this, particularly the 1011 translocation, as a poor risk feature, and some are using the 1119 translocation as a good risk feature. But as a general rule, there's no standard requirement for using the KMT2A rearrangement in your risk stratification. Of course, as I've said, that there are less good risk features, so less inversion 16, less 821 translocations, etc. The one very specific subtype of AML that is seen in infancy is the acute megakaryocytic leukemias. Formerly, it was the AML M7. So the acute megakaryocytic leukemias in non-Down syndrome children occurs mainly in infants. Some infants will show a translocation 122, non-Down syndrome children, which includes the RBM15 and the MKL1 genes. There is some evidence that this may be a better risk outcome than those patients who don't harbor a 122 translocation. And in that case, however, this is not universal. And there are other studies that have shown that that doesn't really impact on the outcome for these patients. I have a bias because my only patient with acute megakaryocytic leukemia who survived with only chemotherapy and no transplant was a patient who had a 122 translocation. And so I have a little bit of a bias, feeling that this translocation is actually better risk. All right. So your chemotherapy is going to be exactly the same that you would use in older children. It's a standard induction therapy, for example, with ADE. And then post-induction stratification of therapy is based on risk features. It's achievement of remission, MRD status, where you're using AML MRD for stratification, cytogenetic abnormalities, as you would with infants or AML, which has monosomy 7 or 5q minus or other poor risk features. AML subtypes, again, acute megakaryocytic leukemia could be considered as a poor risk feature. And of course, availability of stem cell donor, where if you've got a high risk feature, you may want to stratify the therapy based on whether there is a viable transplant donor or not. There is an increased risk of acute and long-term toxicity. Aziza just gave a talk on long-term toxicity, and certainly the effect of treatment, both chemotherapy as well as radiation therapy when it's used in infants does seem to have more of a long-term effect. And some of this, of course, is because of the changing physiology that results in alterations in pharmacokinetics. And so very rapidly, the way we metabolize the drugs that come in, the P4P genes, etc., are more changed. There's more change of them during the first year of life, and therefore our ability as infants to tolerate and handle chemotherapeutic agents varies significantly. All right, so now we move on to ALL. I'm going to spend a lot of time sharing data with you that was published by Dr. Peters et al. On the Interfant 2006 protocol. This was published last year and really is the largest multi-institution, multinational study done on infants with ALL. And therefore, with the largest cohort, even the epidemiology and clinical characteristics becomes much more significant here. So as you can see here, this is clinical characteristics based off of 651 patients with leukemia. If you look at the quarter that their age, first 3 months or second 3 months or third or fourth 3 months of life, it's almost identical. So it almost comes out to about 25%. The white cell count, the gender here shows a slight female preponderance, which was also seen in other studies. This is somewhat different from what is seen in a lot of other childhood malignancies, where there's a slight male preponderance. As I said earlier, these patients tend to present with much higher white counts than older age ALL. And as you can see here, slightly less than 50% of patients had a white count less than 100,000. And so over 50% of patients presented with hyperleukocytosis greater than 100,000, and actually 29% of them presented with white cell counts of greater than 300,000, which is significantly higher. And really scares us when we see these little babies come in with these counts. The phenotype, as I have said earlier, is predominantly B cell. T cell ALL is really small, and it really accounted for only 1% of these 650 patients that were enrolled in this study. 4% of patients, the leukemias, fulfilled the criteria for mixed phenotype acute leukemia, and in 1%, or about 6 patients, there was an acute leukemia of unknown origin or uncharacterizable leukemia. There's much more CNS disease as well. As you can see here, 13% of patients had CNS positivity at diagnosis, and in 19 of them, it was not evaluable. So certainly the percentage could have been higher. So what about cytogenetics? So of these 651 patients, 73%, so almost 3/4 of all of these patients had a KMT2A rearrangement. Only 26% had germline KMT2A status or unrearranged status. In 1%, there was not known, but that's really minor. That's only about 6.5 patients here. Now, when we look at these 73% of patients, what kind of translocations were there? And again, as I had alluded to earlier on, the majority of 44% of these patients had the 411 translocation. 22% had an 1119 translocation, 11% had a 911 translocation, and another 8% were other defined translocations involving the KMT2A. Now again, I want to remind you that this particular gene, the KMT2A gene, is known to associate with 94 known translocation partners. In 15% of these cases, the translocation partner was unidentified, and likely this was because they just done a translocation, so maybe a breakaway fish was used to identify the translocation or the rearrangement. So treatment, the Interfant 2006 was the largest, is the largest multi-center international protocol that's ever been run. The strategy now is being taken forward as the global strategy. And the plan is
that this is going to be with participation of the Interfant group, COG, and the Japanese CCLG. So really, this is really going to become this, the strategy for the care of infants with ALL, and therefore I've really focused on this. So the risk stratification for this, on the basis of the Interfant 99, the results of that, 3 risk groups were identified. Low risk patients were those who had KMT2A germline, regardless of age. So anybody who had a germline KMT2A, and if you remember from the previous slide, that is 26% of patients, as you can see here, were considered as low risk. High risk was the presence of KMT2A rearrangement with an age less than 6 months at diagnosis, with a white blood cell count of more than 300 or 1,000 or more, or with a diagnosis with a poor prednisone response. And the medium risk was everybody else. So KMT2A, regardless of age, white cell count less than 300, and a good risk prednisone response. And this is the arms. These are the different arms of that particular study. And I'll go a little bit in detail with this as well. So once the MLL gene was identified, whether it was germline or rearranged, germline, of course, this is the top line is the low risk patients, and these go into these, this arm. The bottom line is the medium risk and the high risk patients, again, go through an induction, and then post-induction, there's a randomization where they were testing the addition of AML type therapy in this protocol, because there's so much myeloid expression in these patients. The randomization, or the study question here was if replacement of the protocol 1B by ADE and MAE would improve the outcome for these patients. A subset of patients was taken on to stem cell transplant, and these included all patients with high risk ALL and those medium risk patients who had an MRD greater than 0.01% or less than 10 to the -4. So this is again identifying the study question, and there's the MRD for that. So induction was again with a prednisone pre-phase followed by a dexamethasone for 28 days, so 21 days of dexamethasone full dose with a 7-day taper. Vincristine was given weekly for 4 doses, and daunorubicin was given at 30 milligrams per meter square on the first 2 days following the pre-phase. In addition to this, there is multiple doses. I think this is about 2 weeks almost of daily RRC at 75 milligrams per meter square per dose, as well as asparaginase twice. PEG asparaginase is given, and intrathecal is for CNS negative patients was given twice during induction. For CNS positive patients was given 4 times. This is intrathecal methotrexate with additional intrathecal RRC and prednisone given on day 15. Protocol 1B was basically the augmented BFM strategy, which includes cyclophosphamide 6-MP, blocks of cytarabine, and intrathecal chemotherapy. This is followed by what they called MARMA, which is again high-dose methotrexate, 2 doses along with 6-MP, followed by high-dose RRC and asparaginase, a so-called Capezi-2 protocol. So fairly intensive lymphoid and myeloid directed therapy. Following this was a re-intensification phase, which again, they called it the Octada. Again, dexamethasone, 6-TG, vincristine, daunorubicin as the first part, along with pegasparaginase, blocks of Ara-C, intrathecal, followed by cyclophosphamide and 6-TG. So again, things that we are sort of familiar with addition of much more Ara-C as it's seen here. The dose reduction and the dose modification was based on age for children less than 6 months and children between 6 and 12 months. It's only for children who are greater than 12 months at that particular phase of chemotherapy that they actually receive full dose chemotherapy. There are, of course, exceptions for that. For example, pegasparaginase and intrathecal chemotherapy. So what were the results of the INTERFANT 2006? So 92 or 93% of patients actually achieved a CR. 3.7% died during induction. So a higher induction mortality than what was reported in older children with ALL. And also a higher incidence of 3.4% did not achieve CR after induction. So this again was higher than what is seen in older children as well. There were also many, many more relapses than is seen in older children. So 37.5% relapses. Majority of these are bone marrow or bone marrow combined with other sites. Isolated CNS relapse was also seen in about 10% of infants. And these are the outcomes. The probability of survival, as you can see on the left-hand side, the overall survival is about 60%, with an event-free survival that's is at about 45% here. When you compare that, if you look at the little table at the bottom of this graph, when you compare that with INTERFANT 1999, you can see that it was almost identical, with a 4-year event-free survival of 47 in INTERFANT 2006 and 47 in INTERFANT 2007, INTERFANT 1999, sorry, and with an overall survival of 59% at 4 years for INTERFANT 06 and 56% for INTERFANT 99. So there was no change in the overall survivals for these patients. Again, the event-free survival was very, very strongly related with the risk. Children with a low risk, that is those patients who were KMT2A germline, did almost as good as older children, non-infant children. However, patients with medium risk and poor risk did significantly badly, with a outcome for the high-risk patients of just about 21%. All right. So this was a very interesting analysis that they did. So the INTERFANT group originally included all of these countries, and I'm not going to, all these institutions and countries and groups, and really included the UK CCSG, the French Leukemia Study Group, BFM, AIAOP from Italy, etc. So lots of very, very well-established groups. And however, the 2006 study, in addition to all of these, had others. And these were also very, very established groups. For example, the Australian and New Zealand Children's Group, the Seattle Children's Hospital, Chinese University of Hong Kong. So really, really good other institutions as well. However, what was seen was a significant difference in the survival probability for these patients. And this was seen in all three categories, risk categories, the high risk, medium risk, and low risk. And this is on the curve C is for the original group, and curve D is for the new inclusions for the INTERFANT group. And again, what they proposed here, the hypothesis they proposed for this difference is understanding usage of that particular protocol. So even for very, very established study groups and institutions, there's really a learning curve. And this is why I wanted to show this up here. So here, these are very, very toxic and very poor risk protocols. All right. So what was the probability of event-free survival based on the KMT2A status? And again, as we've seen in there was a significant difference between there with those patients. These are the low-risk patients actually doing almost with an event-free survival of almost 80%. And if you look at the probability of survival of patients with a germline KMT2A, this is really very similar to that what you see in older children, with an overall survival approaching 90% and an event-free survival of about 75%. So when they looked at the randomization, the one randomization in here was the addition of, or the replacement of the protocol 1B with AML therapy, ADE and MAE. And again, as you can see from the Kaplan-Meier curves that I've shown in here, that the number of relapses, deaths, and a consequence disease-free survival or overall survival was identical. So there really was no benefit of adding these purely AML type therapies to the infantile protocol. They also went ahead, and because of the very large cohort that they were able to study, they also went ahead and looked at the different translocation partners, the common translocation partners 411, 911, 1119. And again, as you can see here, that the outcomes for 411 and 1119 were somewhat poorer than those for the other two. And this achieved statistical significance. Age continued to have a factor, as you can see in the top right-hand corner here, with the younger children doing worse than the older children. Some of that obviously is to do with the presence of the KMT2A rearrangement. White cell count also was on univariate analysis, was a significant prognostic marker, as was the prednisone response.
And Dr. Asim, only 2 minutes are left.
Sure, I'm just coming to an end.
Okay.
Thank you. On multivariate analysis, the strongest prognostic factor was KMT2A status, with other prognostic variables that did show independent effect was age, white cell count, and diagnosis, and the prednisone response. The gender and CD10 status did not show anything else that. So finally, I'm just going to talk very quickly about stem cell transplant. So the event-free survival for the high-risk group was 21%. And this was with an intention for transplant for all of them. In actuality, only half the patients actually received stem cell transplant. 54 suffered an early event before they reached transplant. And this, therefore, those patients who reached transplant were possibly had a biased better outcome for these patients. Of those who were transplanted, the 76 patients, 34 relapsed, 18 died due to transplant-related toxicity, and 2 developed second malignancy. And therefore, the disease-free survival for those patients who underwent transplant was 44%. There was significant transplant-related toxicity. And as you can see here, that initially where they were using a busulfan cyclophosphamide melphalan protocol, the transplant-related toxicity was 26%. And then subsequently, when that was changed to either busulfan or triosulfan with fludarabine and thiotepa, the transplant-related toxicity reduced significantly. There are some novel targets that can be used that are coming up. FLT3 overexpression has been shown, and this was tested, lestortinib, which is a FLT3 target, was tested by COG and really did not show an improvement in outcome for MLL-related rearranged ALL patients. Other things that have been identified is epigenetic targets. Genomic studies have revealed a paucity of cooperating genetic alterations in this, and therefore there are multiple genetic lesions that, multiple epigenetic programs that are in place here. CpG methylation is one, and azacitidine is used as a demethylation agent. On the other hand, histone deacetylase inhibitors with romidepsin and panobinostat have been found to be effective in preclinical studies. A pilot study of decitabine and vorinostat combined with reinduction therapy for relapsed infantile ALL really led to excessive infectious toxicity and no real benefit in there. Immunological targets, blinatumomab and CAR T cells have been identified. However, one of the problems here is that CD19 and CD22, which are targets of these agents, is not expressed universally, and CD19 de-expression has also been shown. There are also RAS pathway targets that are being identified and studied. So in conclusion, infant leukemia is difficult to treat. There is an inherent chemoresistance, particularly of ALL. There are immature and changing pharmacokinetics for infants, and therefore that results in a problem with giving appropriate doses of chemotherapy. There is increased acute and long-term toxicity, and there are diverse genetic drivers that limit the ability to determine targeted therapy. Thank you very much.
Thank you, Dr. Asim, for an elaborative talk on infantile leukemia. We will take question answer at the end. Our next speaker is Dr. Shakila Khan. She is pediatric oncologist at Mayo Clinic, and she is going to talk on breaking bad news with social distancing in COVID-19 era. Dr. Shakila, please unmute yourself and share your screen.
Assalamu alaikum, everybody. I hope that everybody is well. Thank you for the invitation from the Shaukat Khanum organizers. Dr. Najma, thank you. I wish I could be there, but at least I'm present virtually. But I have to say this, I'm very impressed with your organization. This is amazing to me. And so Dr. Najma contacted me and said she wanted to, the topic is communicating bad news during an epidemic like COVID-19. I think there's some problem with my video because I've started it, but it keeps on giving me that, so I'm not sure. So anyway, I thought that this was interesting because it is a difficult topic anyway, and to do it not in person was a big challenge. So I thought that I learned a lot while I was preparing my talk about how to do it because there's not much available in the literature. So these are I have no financial obligations, and these are my objectives. Learn how to communicate with and without face-to-face contact. I think that is the major challenge, and how to do it while you're doing it via a telephone or a video visit. And the main thing is, how do you convey your empathy and sincerity when you're not in the same room with the patient, because that makes a big difference when you're doing it in person. So of course, in pediatric oncology, we do new diagnosis, discuss serious side effects of treatment, relapse or progression, palliative care transition, and end of life and hospice care. So these are what we deal with. And normally it's very difficult to do because it is, as physicians, it's very difficult for us because we are not comfortable giving bad news. We are trained to heal and cure, and this is very hard for us. And I see that in some physicians, and that's why I think this has become a good topic for discussion. Usually it's done in very rushed communication with a lot of what we call med speak, means using medical terminology, which a lot of families can't understand. Sometimes it's an unemotional delivery of information and lack of empathy perceived by patient and family. What are the traditional tools we use for face-to-face? I'm going to start with the face-to-face. Of course, I still like Buckman's 6 steps, but now people do Spike Guide, and I'll talk a little bit about Vital Talk, which is a very good website, which I think you guys should explore. So Buckman actually came up with this 6 steps, which I think I still use. First of all is get the physical context right. You need to know what exactly is happening with the patient. You know, we get referrals, and sometimes the family shows up and they have not even been told that there is a concern for cancer. So it's good to find out how much they know. And sometimes, it is hard for them. So we just have to say, just give the news and have another session for following that one. Sharing information, do it in a succinct and clear manner. and respond to the patient or family's feelings, because sometimes you should be prepared for strong reactions. I've been doing this for a long time and I've seen that happen. So it is important that you are prepared for any situation, and then of course plan and follow through. It's very important after you give the bad news that you have a follow through and meet with them again, because half of what you say they don't hear. Spikes is very similar to setting up the interview, perception of the patient, then obtaining the patient's invitation, giving knowledge and information to the patient, addressing emotions and empathetic responses, and step 6 is strategy and summary. So it's made pretty similar. And guide is also what some folks use. Everybody likes to use what they like. Again, it's the same principle: get ready, understand what the patient knows, inform, start with a headline, demonstrate empathy, equip patient for next steps. So a little bit about this website called Vital Talk. It's about communication skills for serious illness. And our palliative care physicians the younger ones got a grant to train the residents, and it was very well received. So you can get this is a good resource to have. So find a setting that is conducive, and you're doing it in person. I'm still going on about, you have to make sure that you are not disturbed, and you use appropriate body language and eye contact, and now allow patient or parents to identify who they want with them during the discussion. I actually had made a tape at Baylor when I was there about how not to do it and how to do it, but I think now that is a little old, but it addresses all these issues. Absolutely determine what the family knows and what they have been told. Make no assumptions, ask questions, and listen to them carefully. I think this is a fault we all have. They timed physicians and they discovered that how long was the interval before they spoke again, especially in such situation. And I think it was 10, 12 seconds. So we have to remember to keep quiet and be silent. And it is important to determine the patient's and family's understanding of the situation to help you learn how to tailor the information accordingly. When you're giving the information, start at the patient's or parent's level of comprehension and provide a brief overview. Always give a fair warning. I'm afraid I have some bad news. Present the news in a succinct and direct manner. Don't go roundabout. I've seen physicians do that. They would not use the word cancer, or they would not tell them what is going on. Avoid medical jargon, make it as simple as possible, and allow the news to sink in. After you have given it, give it a little pause, sit quietly, and wait for them to really assimilate that and ask you questions. Adjust your style to the patient. Actually, it is really, you have to respond to the family's reaction, allow for expression of emotion, be prepared for strong reactions. Once I had a family, actually this patient is a long-term survivor, father started screaming and mother was sitting quietly, and we didn't know. So we had to call in a social worker to take away the father in another room for him to recover. And, it took him a time to come around, but he did well after that. And they come regularly for long-term follow-ups and, are doing well. Acknowledge their feelings. That's very important, and be around for their support. After you're done with that and you're closing the visit, summarize the major points you discussed, ask if they have any questions, agree on a specific follow-up plan, and make an appointment for the next meeting or follow-up conversation. So if in the hospital I have a new diagnosis, I go and tell them that and sit down, take them, as I said, to a quiet place, sit down. But then I say, okay, I'll come back at certain time to see you again and do a follow-up conversation. So I think that is important too. So this was how we do it, right? But COVID-19 has made a big impact on how we conduct our business of caring for the patients. And we have to keep our immunocompromised patients safe and continue treatment. Wearing masks and social distancing have become important tools for us managing these patients in person. And we are doing more telephone and video visits where patients are not on active treatment. Actually, at Mayo, you cannot enter either patient or staff without a mask. You have to, and for us, we have to. So I always said that cancer doesn't stop for anything, and that's what we did. In COVID, we just have to figure out how to take care of our patients. So questions with COVID-19 for bad news is, shall we do it in person with social distancing and masks? Would that be the same when we can't touch or comfort our patients? If we can do it in person, how do we use telemedicine effectively? And if we use telemedicine, how do we convey the news in an empathetic and humane manner? These are the questions which come up when you're not doing it in person. So I decided to do a literature search for oncology communication, and there's not much available, very few abstracts. I think this is a new thing which is coming up now. I know I found only one related to pediatric oncology, and I actually listed my references. So the pediatric oncology practice with COVID-19, I think most of the places, and I asked Dr. Najma about it too, have maintained normal care while implementing the safety measures. That's what we have started doing. Wearing masks, eye protection for physicians, and PPE with protective care when needed. We have COVID positive patients. So, and then patients wearing masks and practicing safe distancing and testing for COVID periodically. We do test patients before any procedure, before every new cycle. So, and hospitalization for chemo, of course we do that a lot, but now we have a restricted visitor policy. We just have one visitor allowed, which is difficult in pediatrics. And if they're over 18, nobody's allowed to come with them or stay overnight. So these are the challenges we are facing. So breaking bad news with masks and social distancing, and this is an unexpected new challenge. Masks are protective, but a barrier to conveying and discriminating emotions. They can't see us. The only thing patients see are our eye expressions. But there is something about silent communication with long looks without words, which may have more impact than long talks. But the question is, would the parents and children feel the same as half of the physician's face is covered? They can't see us. And social distancing prevents hand-holding, hugging, non-verbal elements to show compassion. I'm a hugger, so I actually had to figure out how to restrain myself. Do we break social distancing to show compassion? And will it be acceptable to the patients unless it is pre-agreed upon, as it could be perceived wrongly? Some people are really scared. So this is a major issue that probably you have to ask permission that if you can touch them. So just to give you a little couple of cases, which actually I did my talk for my colleagues before I doing it for you guys, and he gave me this story about what he had to face. We actually have a very unusual case with a new diagnosis of ALL and neuroblastoma simultaneously. I've never seen that ever. And we have asked around, so it's very rare. And this happened just when COVID had started and we started wearing masks. So my colleague took off his mask. He took them to a separate room and he asked permission and took off his mask so that they can see him, and he thought it would be better for the family while maintaining social distancing. And the family actually told him later that they appreciated his gesture because, at least they could see him and talk to him. There was another one, a 9-year-old with new diagnosis of leukemia with a high count who was in the PICU for a short period. And the family was devastated with the news and were having a hard time with acceptance, and they were not very good with wearing masks. So the physicians there were not sure if they should enforce the rules for them without appearing insensitive and how to do it well, because they were dealing with this new diagnosis and it was very hard for them. So I think so. The bottom line is that you have to adjust to the patient's reactions. Also, we have one visitor policy in the Children's Hospital, which is an issue, as patients can't bring any family members for support like we would do normally with an in-person visit. I mean, we always ask them, who do you want with their, when we are talking. So that is always an issue. Now, because we can't, even both parents can't come. So how do we do it remotely? I think the first thing is to set up an appointment for a video visit, preferably. I think it was still better to do a video visit like Zoom or Skype, as being able to see the person will make a big difference. But if patients don't have sometimes have resources to have a video visit, then we do get telephone visit. So of course you'll have an appointment for that. Apologize for not doing it in person and explain why. And of course, for pediatric patients, we usually ask the parents if they want the child to be there with them, especially when they are older. And, there are a lot of virtual consultation tools using organizational resources versus other resources. So like you are having Zoom, we have Zoom, we have business Skype, FaceTime is available, WhatsApp. So I think the main thing is that you have to be cautious about confidentiality when using any tool. But I think being able to see the person may be very, very helpful. And that would help you assess and respond to non-verbal cues, because on the telephone, it would be hard to understand and assess that. Prepare as you would for an in-person visit. Keep the structure as outlined previously for a face-to-face visit. Make sure you and the patient and parents are in quiet rooms and unlikely to be interrupted. If possible, ensure they have somebody of their choice with them for support. Give a warning shot about the news and convey the news in a simple and succinct manner. I think tone of voice and empathetic language is important. And I think this is very, very important. Listening is as important as speaking. Allow silences, acknowledge emotions, and reassure crying or weeping is acceptable. Because you can have a lot of emotions when you're, giving bad news. Before closing the conversation, check if they have any question. Finally, closure is important with a robust follow-up plan. Of course, you will document your conversation, but I think this is very, very important. When we give bad news, it's hard for us to. So after you're done, self-reflection and debriefing is very important, I think. And we usually, ask and tell colleagues, and we give each other support. We have always done that because it takes toll on you also when you're dealing with this. So you have to make sure that you are taking care of yourself. So this was via video, but if you don't have that choice, then we do it on telephone. If you're doing it on telephone, tone of voice may be more important when you can't see the person. Again, the same thing before the visit, ensure you're well prepared and in a quiet place without disturbance. Speak clearly and give news in simple terms, not using medical jargon. Be honest and empathetic. Use silence to allow them to react and process each part of the discussion. And it's very important to see if they have any questions at the end of the conversation. Develop a follow-up plan, document your conversation, and have time for self-reflection and debriefing. So I'm hoping that these strategies will help us learn how to communicate and show compassion and empathy when we are not physically present. There is emerging literature on how to do it and training modules for physicians. There is no perfect way to do it. I cannot tell you how you should do it or how somebody else should do it. But I think the important thing is do it with kindness, compassion, and empathy, because the patient is looking for that from you. And I think that is very, very important. So thank you, and I will be open for questions. These are the references. And we are going to start our winter. So I just wanted to show you winter in Minnesota. Thank you all.
Thank you, Dr. Shakila, for such a wonderful talk and giving us tips to improve our communication skill in this COVID era. So we have one question for Dr. Asim. Dr.
Sure.
Asim, kindly unmute your mic.
I just did.
Okay. So question is, does CNS involvement status change the risk stratification in infant acute leukemia?
So it's of course it's more therapy that these patients get. The Interfant study 2006 didn't specifically look at that, and they didn't stratify those patients according to CNS disease either.
Okay, that's fine. So I have a question for Dr. Aziza. What's the role of giving growth hormone after achieving the linear growth? Is there any role of growth hormone?
Well, it depends on what kind of growth you're achieving. Growth hormone is usually given to children who've had a bone marrow transplant. That is usually the scenario under which we use growth hormone. We look at them, we get the endocrinologist involved, you look at what their anticipated height would have been, you do their bone age, you see if their epiphyses are fused or not, and then you make a decision about giving growth hormone. If they've already achieved their linear height, it really does not help.
Okay, thank you. So my other question is about the fertility preservation. So being in a lower middle income country, families usually have the financial constraints, and we have very limited opportunities. So what you recommend, what we should do in such cases?
I think anywhere in the world, but particularly in our countries, there is a culture of having children, right? And I don't think that, this is just philosophically I'm speaking, you should never deprive somebody of having a child if you can help it, right? Cancer treatment is expensive anyway. In young men, you know, children 12 plus are able to do sperm banking if needed. And they are more vulnerable than females anyway. So I think that that opportunity should be afforded to parents and patients so that they can bank the sperm of their child. Doing testicular, freezing testes, which is now being done in very young children, there's no real proof yet as to whether it's going to work or not. But sperm banking is something, and I've seen it over the years, where young men have become infertile, but because they had sperm banked, they were able to have fertilization of the ova and have embryos and live births through that. For women, the ovaries are pretty resistant. If you have to radiate somebody's abdomen or pelvis, you can always take the ovary out of there and transpose it into another part of the body if needed. We've also done ova cryopreservation. I think that is kind of impractical at the moment in low and middle income countries. But for young men, I think that sperm banking is something that we should seriously think about.
Okay, thank you. Any other question from panelists or from participants?
Yeah, I agree with with Aziza, because I think we have started doing, sperm banking has been here for a long time. And we have had, a lot of patients have had babies after that, and it's good for us to see that. But ovarian tissue preservation and ova preservation and testicular tissue preservation has started. It's experimental, as Aziza said, but it is becoming more common. We have started doing it on all of our patients especially who fit the criteria, younger patients. So
if there is
actually, I'll plug it in. Asma Chatta is one of the people who does it for us at Mayo, and she would love to come and talk to you guys. So next time, I put in a plug-in for her last time. So she is the person who organizes it for us.
She's most welcome.
Shakila, it is really amazing how important that is, because when a child is diagnosed with cancer, no matter what the age is, the only consideration in that child's mind, or if he's an adolescent or young adult, or in a parent's mind is, I want to save the life of my child, right? How many times have they refused? We don't care about sperm banking. We don't care about anything, just save his life. But then when that child survives, and becomes 20 or 22 years old or 25 years old, that's when I get all the questions. Why didn't you insist that
Right.
why didn't you convince me to do it?
Right.
Yes.
So,
It's a deprivation in sort.
Yeah. Can you hear me?
Yes, Mary.
Yeah. No, I was just going to agree with you, but I was just going to say that, as you say, ovarian and testicular cryopreservation is in its infancy, and we don't know whether it's going to work in the long term, as you say. And for us, it's not funded on the NHS, so I'm not sure how it's funded in the UK. We've got a big charity that does it, so we've been doing it for a number of years now, and we'll
Right.
see how many of these children will have babies in the future. But it's huge, it's big, something that we can offer. I mean, I feel better once I do it. And again, I have to tell them that it may not work, but they all want to do it as well. So I think it's very important, but it is something that's still for the future, I think, in Pakistan.
right, it is.
But yeah.
Yes, but you know, they actually, the parents have to pay a little minimal amount per year, just like sperm banking, they have to pay for that. And they are willing to do that most of the time. We initially had a grant, but now it's sort of becoming more standard. But there have been some publications. Asma always sends me when there have been successful deliveries, pregnancies, deliveries. So I think
that's why we do it.
Yeah,
Yeah.
it is.
So in Pakistan, how could we? How is it? Is it available at all, or no, not
So-
at all, Najma?
So
Sperm
in Lahore,
banking.
there is only one center in private practice which offer this, but it is a bit expensive. So
Yeah, I think the
usually
same thing in
families
Karachi as
can't
well.
afford.
Yeah.
The Karachi as well, like, there's limited in the private sector, which are fairly costly. And so a very, very limited proportion of our patients can actually afford it.
Yeah.
Right.
And again, also because it's got to be maintained and paid for years and years and
Right.
years,
That's the main thing.
right? The cumulative
parents
cost
pay
actually is
too.
very high.
Yeah.
Yes, I know. Because even on the NHS, after 10 years, they ask you, they find out whether the patient is still alive or not, do they still need them? Because it is a huge cost if you do it on a population-wise basis.
Yeah. But it's good when you have successful pregnancies. I've had,
Oh, amazing. Yes.
you know, even in females. So
Yeah.
it's,
Okay, if there is no question, then we can close this session. I'm really thankful to all of you for making this event successful, especially Dr. Aziza and Dr. Shakila. Despite the time zone difference, you made this.
I actually forgot that we changed our clock. So it was 1 hour earlier for me.
Earlier,
I didn't sleep at all because I was
So
so.
I've been up since 4 o'clock.
I got up at 3 a.m.
Yeah, sorry, Dr. Mary, I forgot to mention. All of you really, it is because all of you did this event was successful and we made this.
No, actually, as I said, I wish I could come in person. I love coming there.
Yeah, I would know.
Hopefully,
I think that's the general consensus that even though we are seeing each other virtually, it really doesn't sort of replicate what we would have had when we're all together.
Exactly.
We thoroughly enjoy ourselves in the Shaukat Khanum conference every year.
Inshallah, next year. Inshallah.
Inshallah next year.
Yeah.
So we know
Inshallah.
more of it. Biden will be the president, and we'll all.
Yes, I'm hoping for that. I live in Aziza, you and I live in a blue state. I'm so happy about that.
Wonderful.
Trump was
Thank you,
trying to
everyone.
turn Minnesota, but he wasn't successful. Although we have a lot of Republican, state representatives. But, but hopefully,
Amazing how many people have voted for Trump. I cannot believe it.
yes, but you have to.
68 million have voted
No,
for
exactly. No, it's a cult. It's a cult follower. The people are cult. Trump is a cult.
Huge,
Actually,
huge cult.
I know a lot of Republicans who have left the Republican Party because of that, because it's become a cult.
Yeah.
So the real Republicans are not there.
Let's pray that Biden wins. It's still on a knife edge.
Yes, it is. Yes,
Look at
please
that,
do.
Arizona,
I've been telling
Pennsylvania.
everybody to pray. Yes.
I'm following it up. I'm sure you're following
Oh
it
my
up.
God.
I haven't slept for 3 days, guys.
Yeah.
I know. I didn't sleep that election night.
So this is the part where we go for the dinner and have this discussion.
I know.
We're having that dinner
Absolutely.
now.
Yes, this is the part.
Because we
Yes.
suddenly
Very
forgot that we
interesting.
were in a conference.
Yes.
Oh,
No,
yeah.
don't worry. I had my AAP meeting this afternoon. Everybody was talking about elections. So it's a topic, hot topic everywhere.
Shakila, I actually remember when Trump got elected, we were at Shaukat Khanum.
Yes, I
It
was on the
a
plane.
conference, and I know how depressed you were.
I know. I was on the plane and I looked at the results and I was like, oh my God. I remember it. Yes, Asif. Couldn't believe that.
It's still, oh my God, look what he's doing. He's saying this election
Oh,
is
you
a
know what he's
fraud.
doing? So he's trying to stop physicians from coming. They have put a new thing, which we all protested. J1 visas, they're cutting back. H1 visas for physicians, they're cutting back. He's trying to just cut back on everything. So actually all the medical organizations here protested about it because 40-50% of the medical care is provided by what we call IMGs, International Medical Graduates.
Yeah.
So this is a big thing here. So AAP and everybody, they're all anti-Trump. So
Yep.
that's what we were talking about. Very few are pediatricians would be for Trump, I can tell you.
I know. Let's hope it all
So-
succeeds and Biden's confirmed.
With excuse, session time is about to finish.
Yeah.
Yep.
Thank you so much, Najma. Thank you so much.
Najma, thank you. This was very well organized.
Pleased. Very well
I'm very
organized.
impressed. I'm
Thank you
very
to all
impressed.
of you.
Yeah.
To,
But you know, like it always happens in real life as well, when we're all there physically, we end up chatting during during our sessions. I think exactly the same thing has happened here.
yeah. So once again, I am thankful to all of you to give us the opportunity to share knowledge and learn from each other.
All right.
Thank
And you
you.
guys take care, everybody.
right. Thank
Khuda
you.
Hafiz.
Thank you.
Hafiz.
Goodbye.
Khuda Hafiz.
Goodbye.
Yes.